Thank you everyone for being here with us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services and Mohammad Naeem Siddiqui, Regional Sales Manager, Varanasi Region from Jagsonpal Pharmaceuticals Ltd, are delighted to welcome you all to the today's program, Scientific Sangam 14, on part 2 of Umbilical Cord, organized by ISOPARB Prayagraj in association with Allahabad, Trichy, and Bareilly Obs and Gyne Societies. The academic partner for this program is Jagsonpal Pharmaceuticals Ltd, makers of DIVATRONE 10 mg tablets of micronized dydrogesterone for safer and smoother journey to the motherhood. Injection Maintane 250 and 500 mg depot 17 alpha hydroxyprogesterone caproate and LycoRed Preg sachets of L-arginine, lycopene, and DHA for high-risk pregnancies. We are thankful to ICOG for granting this webinar 3 ICOG credit points. A warm and hearty welcome to all the esteemed faculty and the attendees. Dear attendees, if you have any questions, suggestions, and clarifications, please post them in the chat or Q&A box. Please note this webinar is streaming live on the Facebook. The link is shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. Now, we welcome and request the organizing chairperson of the program, Dr. Ranjana Khanna ma'am, founder, president, ISOPARB Prayagraj, ICOG Governing Council member, and National Vice President, FOGSI 2017, to kindly take the proceedings further. Over to you, ma'am.
A very good evening and a very warm welcome to all the faculty and all the delegates who have joined together. And I would like to thank the Allahabad, Bareilly and Trichy societies for joining in with us, ISOPARB Prayagraj. So first of all, before we start any our program, our scientific program, we'd like to begin with the Mahamrityunjay mantra. Today, I have immense pleasure in introducing the chief guest of the program, my very own, my very dear, the dynamic Dr. Meerak Newtree, ma'am. She has been my teacher. In fact, she has taught me all the nuances of obstetrics. And what to say about her? She is a teacher and a human being par excellence, a very devoted wife, mother, and of course, a very devoted teacher. So it gives me so much pleasure that when I just see her, you know, my heart goes woo, woo, woo. So Dr. Meerak Newtree, ma'am, I want to say one thing, that you have never really changed over the years. I still have the same memories of you when I first met you when I was doing my house job in Obs and Gyne. So I want to officially also introduce you as Professor and Head Obs and Gyne, GSVM Medical College, Kanpur, of which I am an alumni, X. Presently, Chairman, Ethics and Research, State Medical College, President, WWW Foundation, Managing Director, Hospital. She's been the organizing chairperson of International WWWCon, the first ever any conference inaugurated by the President of India and Union Health Minister. Only you could have done it, ma'am. And ICOG Ratna Samman Golden Plaque, I was there to witness that. 63rd AICOG 2020 at Lucknow. Best FOGSI Focus Award, Women Empowerment Award, Lifetime Achievement Award, and Lifetime Achievement Award ICES, Women Empowerment Summit Honor 2019 at Delhi, Teacher of Teachers Samman ISPAT at Delhi 2018. So hearty welcome to you, madam, and I would love you to say a few words of wisdom and bless this conference. And of course us.
Thank you very much, Ranjana. It's really an honor and pleasure, and I must, I don't have words to just say when I see learned dignitaries by me on the dais for speaking and for chairing or for presenting. My very, very dear brother Narendra Malhotra is with me, and you know that I have got a great sense of love, affection and passion for this family, not this time but from the time of his parents and when her mother was alive. हमारा बहुत स्वागत होता था. मैं ये नहीं कहूँगी कि अब नहीं होता है, लेकिन वो मुझे बहुत प्यार करती थी. आई नो कितना भी पेट भरा हो, पूरी और आलू मेरे लिए तैयार रहते थे हर वक्त. So I've got great memories. So when I see Narendra, I simply see that younger brother is sitting by my side. I can see Manju Verma. मेरे नाम से इनका नाम शुरू होता है और हम लोगों ने जिंदगी के बहुत लंबे लंबे अच्छी वेव्स एंड वैल्यूज शेयर करी हैं. तो मंजू को देख के आई एम रियली थ्रिल्ड, आई एम रियली लव्ड. सेकंड स्पीकर none other than Dr. Bhaskar Paul. He's a very learned person, very talented, genius. मैंने कई दफा इनके साथ 2G और 4G मीटिंग्स अटेंड करी हैं और जितना मैं ज्यादा अटेंड करती हूँ मुझे अच्छा लगता है. whenever he comes out with very important salient points. Why? His why is very good. Whenever anything is being proposed, चाहे किसी के द्वारा, he will say why. हमने एक दिन प्यार से कहा कहीं तो मुझसे ये मत पूछना why your name is Meera. So he's a very learned person and really genius, and his words are valued. So Bhaskar, I'm very much thrilled to be with you right now. हमारी third speaker, Dr. Ranjana Khanna, Beauty with Brains. I can tell you that she's very hardworking. और कोई भी काम रंजना को असाइन करा जा रहा है, I don't want to just make a list of the positions she has hold, but what I know that next to the president is the vice president, so she has reached to the stage of vice president FOGSI, which matters a lot. And she has done very many integrated works along with the conferences which she has arranged. And I can tell you all the conferences which I was arranging, as I depend on Narendra, next to her is Ranjana. हम इनको कोई भी ऑर्डर करते हैं हमारा स्पेसिफाई हो जाता है और वहीं पर हो जाता है. So I extend my heartfelt gratitude to you, Ranjana, for making me a part of this prestigious meeting. Next speaker is Shaila. Shaila, I'm not able to see her. She's a young, talented, and very devoted person. I extend my heartfelt thanks for being a part of it. And the organizing chairpersons, if I keep on taking the name, I really love it. Dr. Malathi Prasad, then Dr. Charmila is there. Charmila, I didn't know Charmila is here. Charmila, Lakshmi Prasad, and Dr. Abhilasha Chaturvedi, Preeti, Vash, then
I'll hand over the session now to Dr. Amita Tripathi to please take the session forward. Dr. Amita, we know that she is the honorary secretary, founder secretary of ISOPARB Prayagraj and chairperson of women's wing of AMA Prayagraj. So Amita, please take over the session.
Thank you, Ranjana ma'am, and a very warm welcome from my side to all the faculty and the delegates. So without wasting any time, we would like to start with the first session on a very important topic, the making sense of color waves. And every time, and the speaker is none other than past President Dr. Narendra Malhotra sir. Every time we hear on this topic by sir, we take one or another point to practice in our day-to-day practice. And to chair this very important session, we had chairperson Dr. Malathi Prasad, President Trichy Obstetrics and Gynecological Society. She is at present Director Trichy Fetal Medicine and Fertility Center. She has won various awards like first prize on paper on fetoscopic skin biopsy on epidermolysis conference induction. And she has been on various posts, previously as a secretary of Trichy OBGYN Society, and it's not visible. Okay, welcome, Dr. Malathi. And next chairperson is Dr. Madhvi Mittal. She is a very senior and renowned ultrasonologist from the city of Prayagraj, and she is her understanding of the subject is very, very good. So whenever we are in dilemma, we look towards her. Welcome, ma'am. With this, I request Dr. Malathi to please introduce the topic and the speaker for this session. Dr. Malathi.
I must thank the entire pleasure in introducing this topic, because as a fetal medicine specialist, I really know the significance of a color Doppler wave, especially in managing cases of fetal growth restriction. We have our very, very popular Professor Narendra Malhotra, who's going to talk on this very important topic. I'm sure he's going to bring in a lot of insights into this very gray, at the same time clear topic. Professor Narendra Malhotra is a Managing Director, Global Rainbow Healthcare, Director, ART Rainbow IVF, President, NSARC, Vice President of SAFOG, past President SR. He's a Director of Hindenal School of Ultrasound. He's the Advisor to IVF Unit, Maulana Azad Medical College. He's published over 125 papers, chapters, 500 presented papers, 1,000 guest lectures, and is an editor of almost close to 41 books, and edited many chapters on revising editor, Jeffcott, etc. So with this introduction, I request Professor Narendra Malhotra to start his topic.
I think Dr. Meerak Newtree, ma'am, is back. So, ma'am, if you want to conclude what you were saying, then we can proceed with Dr. Narendra's talk.
Ranjana, you just go ahead. There was some network problem. I don't know, it has suddenly disappeared. But I extend my heartfelt gratitude for making me a part of this. And my blessings are always, always, always with you. And this meeting is going to be very, very successful, because the learned speakers, you know, starting with Narendra and Shaila Jamal to end with. And we expect a lot of things, and we will be going with lovely back home messages.
Thank you, ma'am.
Thank you very much.
Thank you.
Dr. Narendra, please.
So very, very good afternoon, good evening to all of you. It's indeed a pleasure. It's indeed a pleasure for me to be a part of this ISOPARB meeting being organized by Allahabad with Bareilly, Trichy, and all the other societies. So what are we going to talk is this, it is a very good concept that you're talking about, the Funis of Life, the umbilical cord. And the umbilical cord is the one which takes the blood out of the baby, umbilical arteries, and the pure blood inside the babies. So it is the blood flow and the umbilical cord which links life of the mother to the baby, to the developing fetus. And if something goes wrong in those umbilical arteries, the waves tell us, and we need to understand and look at the waves. So it is not, when we talk of, I cannot only restrict myself to umbilical cord and umbilical arteries, because once we talk of color Doppler, it has to be a complete correlation of umbilical artery, fetal aorta, uterine artery, and fetal cerebral. So just a couple of slides on what is fetal growth restriction. Fetal growth restriction is every fetus has a potential to grow. If the fetus does not grow to its potential, it is growth retardation. And it could be because of maternal factors, fetal factors, and placental. The placental factors are more important, because if the placentation is not complete, not proper, then the exchange of blood and the nutrients and the oxygen does not take place, and they don't go to the fetus, or the fetus impure blood does not come back, and that leads to growth retardation and maybe fetal death. So if we look at the perspectives, the fetal causes are chromosomal malformations, chromosomal and other malformations, and multiple gestations, all picked up by ultrasound at the 11 to 13 week scan. The placental factors are abnormal invasion of the trophoblast, chronic abruption of the placenta, filamentous umbilical cord, circumvallate placenta, chorioangiomas. And maternal factors are huge: genetic, nutrition, starving, hypoxia, vascular, renal disease, antiphospholipid syndromes, environment, drugs, infections. So we need to look at all of them to get a clear perspective of what growth retardation. So firstly, you have to identify the etiology. And the etiology, as I told you, fetal, placental, maternal. So fetal by karyotype, placental by Doppler, fetal by anomaly detection by ultrasound, and maternal by doing an infection screen and the environment and the other things, and doing a health screen of the mother. That is how we identify. So what do we monitor in growth retardation? We will monitor, of course, growth, how the baby is growing, by doing regular biometry and plotting them on growth charts. Just doing a biometry is not enough. It should be measured from the previous. So if you do one ultrasound, that will tell you the gestational age. But for growth and growth retardation, there have to be multiple ultrasound charted on this growth chart. This growth chart, if your ultrasound specialist is not giving you a growth chart, please return the report to him or her and tell her or him to plot it, the growth chart. If he's not doing it, then go to Google, type growth chart, and you'll get the growth chart there, print it out and plot it yourself according to LMP and according to ultrasound. Then after growth, if the fetus is not growing, we want to know whether the fetus is having compensatory mechanism, the head sparing effect, as we call it. And then we need to predict that if this fetus is actually hypoxic or acidic. That Doppler will tell us. And then we want to know the environment, whether to bring this baby out from the bad environment inside or the environment is correct. And for that, we look at the amniotic fluid, we do a CTG, and we do a modified biophysical profile. Not a Manning profile, we do a Winsellow's profile by doing only two aspects. So that is how we go ahead and decide or what we need to monitor. Now let's see what happens. So there are spiral arteries, about 120 in the uterus. The trophoblast invades and it tears the spiral artery. So the artery becomes like a vein and it allows a lot of blood to go. So when the back pressure in that artery is... Lakshmi Prabha, please, can you mute yourself? Is your doctor? Yes. So then the blood will come easily. And when the blood comes easily, the back pressure on the uterine artery is not there. Plus the estrogen progesterone from the placenta will dilate the uterine arteries and more blood comes. So the placenta receives more blood and the exchange occurs. So this is non-pregnant spiral arteries. This is pregnant spiral arteries. That is how the blood exchange is there and they will dilate. So when something dilates, then more blood will go. When more blood will go, the exchange will be good. And when the exchange is good, this will all go into the umbilical vein, into the Funis of Life, the umbilical cord, which has one vein and two arteries. Pure blood will go towards the fetus. And impure blood, which is being shown as red because it's named as artery, will come back inside and will have a good exchange here in the placenta, uteroplacental. So let's see what happens. Now this is the placenta, the red is the umbilical vein. The pure blood goes towards the liver, divides into right and left here. Most of it goes into the liver and all the nutrients are stored there. The rest of it, through the connection between the vena cava and this umbilical vein, which is ductus venosus, the pure blood goes into the inferior vena cava. And that opens into the right atrium. We all know that. It opens at an angle. The intra-atrial septum as a whole, the foramen ovale is open. So all the pure blood from here comes straight into the left atrium. Left ventricle, arch of aorta, purest blood goes to the brain and to the heart. And then it is joined by another connection, ductus arteriosus, which is bringing impure blood from the lungs. And the rest of the body gets a mixed blood, purple colored. And this is common iliac, then internal, external iliac. The two internal iliacs end as umbilical arteries. And umbilical artery bring out the impure blood to the placenta. So umbilical artery, the heart will pump, umbilical artery blood will come to the placenta. If fetal heart is not pumping properly, umbilical artery blood will not come out. If the umbilical artery is not dilated, the blood will not come out easily and the baby will suffer from fetal cardiac defects. So the Doppler will tell us umbilical artery, whether hypoxia started occurring, whether the fetus is redistributing the blood, and then it will help us by timing the delivery. And of course, we have to measure the amniotic fluid index to time the delivery. Now here, let me tell you, you have to look at the waves. So in the wave, there is a baseline. And when the heart pumps, there is a systole peak. And when the heart is in diastole, there is a diastolic flow. So in all our vessels, when my heart pumps, my arch of aorta and aorta will get a systolic peak. So that blood will go forward to my kidneys, to my liver, to my intestine. All these arteries are muscular. So when the heart goes in diastole rest, the artery comes back into position, and that pushes blood forward more towards my organs. And this diastolic blood flow is 1/3 compared to systolic blood flow. So your resistant index in all muscular arteries are around 0.7, 1/3. Very clear, very easy to see, very easy to understand. Now, supposing I get an injury in my hand or an infection in my finger. Now my body has to push all the WBC and fighting and all the interleukins to my finger to fight the infection. So it has to dilate my radial and ulnar artery. So radial and ulnar artery will dilate, and the resistance, which was 0.7 in a non-infected one, will now increase. So the diastolic flow will increase to 40 or maybe 50%. So the resistance will fall to 0.5. So benign conditions, the vessel will dilate to about half. Malignant condition, it will dilate even more, and the resistant index will fall less than 0.4. So 60% of the diastole as compared to systole happens. If it happens 0, that means the artery is atherosclerotic and it is pushing blood only in systole and not in diastole. So the organ supplied will get chronically hypoxic and will get diseased. So if we understand this principle, we understand. Now let's look at this. This is a non-pregnant uterine artery. You have systole, you have a diastole. The diastolic blood flow is 1/3 of the systolic blood flow. So the resistance is 0.7. The pulsatility will be 1.2 or 2 around 2, which the machine will tell you. And the uterine artery has a notch. It has a peak diastole. It's an end diastole. So here the resistance, this is non-pregnant. Now, if this pattern remains in after 5 months of pregnancy in uterine artery, that means the uterine artery is not dilated. So less blood is going to the placenta. So this fetus is going to get IUGR and the mother is going to get PIH. So if you see this pattern in 20 weeks in uterine artery, it should ring bells. PIH and growth retardant. What should happen to the uterine artery? This should happen. The systole and the diastole is 50% of systole, and the notch has disappeared. So baseline, that you calculate the diastole length, height, and you calculate the systole height. By looking at the wave, you know this is 50%. The resistance is 0.5. So I'm very, very happy. This happens as early, maybe 13, 14 weeks. This mother will never have PIH and this baby will never have growth retardation. So that is how we use for prediction. The rest of the vessels, we will come one by one, are used for delivery. So we first study the uterine artery. And the uterine artery is very easy to see abdominally or even vaginally. That is the non-pregnant uterine artery or up to 10 weeks. And after that, the notch will disappear and the diastolic blood flow will keep on increasing as compared to systolic. And we call this dilated uterine artery, and we call this good diastolic flow, less resistant flow, low impedance flow, whatever you want to call. And low PI, because PI, if it is high, if it is very constricted, heart will push more forward and you'll get a very high peak, but you'll get a very low diastole. So the pulsatility index is high, it is pulsating, and the resistance will. So this is how we calculate PI-RI. So the uterine artery, if it remains like this, will predict, if it remains like this and does not convert like this, will predict PIH, will predict preeclampsia, and will predict prenatal death. So first thing, by looking at the waves. Now let's come to the Funis of Life, that is the umbilical cord. Umbilical cord has 2 arteries, which are the end of the common iliac, internal iliac, and they bring out impure blood to the placenta. So if impure blood has to come out of the baby, what should happen? Umbilical artery should always be dilated to 50%. Very simple, because the blood has to come out. If it is not, if the diastolic blood flow is less, it is like non-pregnant, then it is bad sign. That means fetal heart will have to pump harder and faster to push the impure blood out. And the small fetal heart, if it has to do that for a long time, will get tired and die, cardiac failure. So if the implantation is, or the placenta is not proper and spiral arteries are not dilated, the umbilical artery resistance will not become 50%. So this will happen around 18 to 20 weeks. So very simple. So now umbilical artery, diastolic blood flow, systolic blood flow. Here it is about 30-40%. Here also it is about 30-40% early pregnancy. And this will keep on increasing. As you can see here, it has become 50%. So that is how we look at the umbilical artery. And if it is like this, we are very, very happy that all the fetus heart does not have to do extra work. And whatever the heart is pumping through the aorta is going out for purification in the to the placenta. So just looking at the wave, you're very happy. So a normal is 50%, abnormal is less, and if it is reversed, that means below the baseline, the wave is coming. So blood, instead of coming to the placenta, is going back into the fetus. So fetal heart को और जोर से present करना पड़ेगा. So absent end diastolic flow or reversed end diastolic flow in the umbilical artery will cause neonatal complication of asphyxia, intracranial hemorrhage, NICU admissions, intrauterine death. And this baby needs to be delivered as soon as you see reverse. So let's see how will you see the wave? This is normal, 50%. This is 0, absent, very abnormal. This is very, very abnormal if it is reversed. And if you're seeing these two patterns and the baby is over 35 weeks, deliver immediately, even after 30. So that's one sign by the umbilical. So umbilical tells us. So when umbilical artery Doppler is alterated, then we start doing the others. And it is telling us hypoxia. And it is telling that the brain is going to get affected. So these arteries, then we start looking at this is umbilical artery, we start looking at this cerebral, and we start looking at the ductus venosus. So, and the timing will be based, if it is more than 32 weeks, it is abnormal, deliver immediately, because this baby will die inside otherwise. So umbilical vein and umbilical artery. Now we come to the cerebral, brain. Brain is muscular artery. Muscular artery, I told you, should have only 30% diastole. So there is no business of brain artery having 50% diastole. So if the brain is having more diastolic blood flow, that means the baby is putting all the blood into the brain. So brain sparing effect is happening. And if that is happening, that means hypoxia is increasing. So it will increase, save the baby till a certain period of time. Then the brain will get congested with so much blood that the baby will die. So cerebroplacental ratio is very important. Umbilical artery should be dilated. Cerebral artery should be constricted. If cerebral artery becomes like umbilical artery dilated, it is a bad sign. So cerebral, you look at the circle of Willis, very easy to see. And cerebral should show less blood flow, high systole, 30% blood flow, very, very easy. This pattern, we are very happy. If you get pattern which increase diastolic blood flow, we are not happy. So we are happy with this, but if the blood flow is increasing, we are not happy. That means brain sparing reflex is occurring, and if you don't correct it, then we come to the third, that is the aorta. In the aorta, the most important is the aortic isthmus. So as soon as the blood from the foramen ovale has come into the left ventricle and gone, the first pure blood stimulates the chemoreceptors at the aortic isthmus. Now this chemoreceptors will detect whether the oxygen coming is less or no. If it is less, it will dilate the cerebral vessels and constrict all the other vessels of the fetus. So brain will get more blood, renal, intestine, body will get less blood. So brain sparing growth, brain will keep on growing, rest of the body will shrivel, asymmetrical growth retardation will occur. Okay. So aortic isthmus pulsatility can be seen and studied, and it should have at least 30% diastolic blood flow. If it does not have 30% absent, then it is a problem. So it should be like this, like the normal. Then we come to the most important vessel, that is ductus venosus. Because ductus venosus is the vessel which is bringing all the pure blood to the heart. So this also should be always dilated. If it is not dilated, then if it is constricted because of whatever reason, which could be chemoreceptor signals or a faulty heart, then the pure blood will not go to the heart and hypoxia will occur. So see what happens. That is how the blood goes into in the fetus if it is dilated. So ductus venosus. And you get a good wave pattern with good diastole. So you could get an M pattern with good diastolic blood. So looking at this M pattern with good diastolic, we are very happy. But if it is constricted, see, it goes back and it comes back. So if blood is coming back, then the diastolic flow is gone. And on the other side, we are seeing reversal. If we see this pattern, this baby will die in 24 to 48 hours. Even if you bring this baby alive, it will still go to NICU for a couple of days because already hypoxia has occurred. And this is the last stage. Actually, acidemia has started. So they'll have to treat. So the pediatrician will have to be. So ductus venosus should show good diastolic blood flow. This is reduced diastolic blood flow and you have reverse diastolic. So what is cerebral placental ratio? The MCA resistance, which is 0.7 as I told you. The umbilical resistance, which is 0.5, should be more than 5. 0.7 divided by 0.5 will be more than 1. So it should always be more than 1. If they become equal, it is bad. If they become reverse, then it is very bad. So then we know that growth will occur, brain blood will go, umbilical RI will fall, umbilical pulsatility will increase, more brain blood, weight will increase, then umbilical flow, then the abnormal CTG comes. So abnormal CTG comes 21 to 30 days after the Doppler has started showing, and then fetal death will occur. So we cannot depend on abnormal CTG for fetal growth retardation. Abnormal CTG tells us that the environment is very bad, deliver a more. Now, to make things simple, there is a classification or staging. Stage 1 is abnormal umbilical artery and abnormal. Umbilical artery has become like cerebral and cerebral has become like abnormal. So the cerebroplacental ratio has become less than 1. Very bad. All have become abnormal, all vessels, stage 2. All have become reversed. All have become reversed. Lakshmi ji, apna audio off kar lijiye, please. Dr. Lakshmi, please off that. Please off your audio or don't talk. Stage 3, all have become reversed. Then they can be A and B depending on the amniotic fluid. If amniotic fluid is less than 5, A, more than 5. Stage 1 fetus, treat as outpatient. Stage 2 fetus, admit and treat. Stage 2 fetus, absorption. Stage 3 fetus, deliver immediately. Very, very simple classification. How should we monitor? We can monitor by, see, biometry 2 weeks, Doppler maybe twice a week or sometimes daily. How should we deliver? 24 to 28 weeks, you discuss with the family. Because this baby will go in NICU for a very long time and may have handicaps. So whether to go do a cesarean for these babies is personal decision. 28 to 32, deliver after giving steroids. 32 to 34, deliver in a NICU and anytime. So 3 of us, myself, Yuil, and in Berlin, in 2015, discussed all this color Doppler and we made a Berlin consensus. And that Berlin consensus tell us when to deliver the babies. 24, leave them alone. 26, leave them alone. 28 is borderline. And after that, deliver immediately. And then we charted the road to death. So if you let acidemia happen, that is reversal, then stillbirth likely to happen. And even after delivery, problem happen. So delivery will depend on prematurity, your NICU, and what stage of hypoxia. Our aim is to give a live baby with intact. So we will manage the pregnancy. If the Doppler, if it is 37 weeks, deliver. If it is 32 over, give steroids and deliver. Less than 32, reversal is there, still deliver after steroids. If it is less than that, then discuss with the family. So we have age-specific prematurity delivery protocols in place. So ladies and gentlemen, to conclude, when Doppler study is normal, especially in umbilical cord and middle cerebral, the diagnosis of growth retardation is doubtful. Normal Doppler tells you it is small baby, maybe constitutionally small. So don't do anything. All pregnancies, yes, if possible, 1 Doppler at 28 weeks. Not possible in India because a lot of people don't even get normal ultrasound. But if you have signs and if you have something which can tell you the problem, please do it. So understanding color Doppler patterns by looking by the practicing obstetrician is very important. You cannot depend on your radiologist friend, apologies to them, and you ring them up, Caesar kare ki nahi kare. That clinical judgment is yours. Look at the waves, analyze them, and deliver. In the conclusion, the Funis of Life, the umbilical cord, is the most important connection between the fetus and the mother. And you have to look at the umbilical cord. You have to make sense of the waves, 50% diastole, 30% diastole, or 0 diastole, that should be. So with those few words, this lovely fetus, which we just delivered and saw by ultrasound 3D, if you have 3D, the fetus will tell you, I am sick. So this fetus is laughing. This fetus is saying worried. So this fetus we had to bring out by looking at 3D because he's getting pain. And this fetus was laughing. So we left it alone for another 2 weeks and we delivered it now. Thank you very, very much for inviting me here to share some of my views about this very, very important topic and very, very one of my favorite topics. Thank you very much.
Thank you, sir, for this lovely ultrasound pictures and very clear message. Dr. Malathi, are you there? Would you like to say a few words? Dr. Malathi? Okay, I request Dr. Madhvi Mittal to conclude the topic.
That was a very well explained topic. It is a difficult topic for a regular obstetrician to grasp, but the more you listen to it, the more things start becoming clear. So just to summarize, the primary role of Doppler is in the diagnosis and management of fetal growth restriction, right? And basically, we're going to find out whether the fetus is compensating hemodynamically for that FGR, and also to find out when we need to deliver the baby. So one thing you must realize is that there is a different flow and pattern for all the three arteries, the uterine artery on the maternal side, as well as the umbilical artery and the MCA. And as long as the umbilical artery shows a positive diastolic flow, even though it may be less than the normal range, but as long as it is positive, you can try to pull that pregnancy up till 37 weeks, beyond which you have to think of delivering the baby, right? So as long as it is positive, you know it is in stage 1, and therefore you go for 37 weeks. However, if the umbilical artery shows absent or reversed diastolic flow, then your alarm bells have to start ringing and you start thinking of possibly having to deliver the baby earlier, depending on what is the period of gestation, what are the other readings of MCA, AFI, ductus venosus, etc. And then you have to time the delivery. There are charts and graphs which will help you decide. It's not like one rule fits all. You have to see all the total picture. And just one more thing I'd like to just mention, that there's a lot of confusion, you know, when it's abnormal and all. So the three major vessels, the umbilical artery, the ductus venosus, and the uterine artery, all of them are supposed to have a good amount of diastolic flow. So the moment the diastolic flow reduces in any of these, you have to start, you know, paying more attention to that fetus. And there is only one set of vessels, the middle cerebral artery, which normally has low diastolic flow. And if that diastolic flow increases, then that is a cause for alarm. So that's just a very this thing to simplify it. And you need to keep talking to your radiologist, because I get lots of calls. The uterine artery is showing very high resistance and there's notching at 37 weeks or 36 weeks. Should I deliver the baby? So uterine artery is not a trigger for delivery at any time during the pregnancy. You have to go by the umbilical artery and the ductus venosus, and the MCA and CPR are kind of supplementary to that. So that's, I think, just a
wonderfully summarized. Wonderfully summarized.
Thank you.
Thank you, sir. Thank you, Dr. Madhvi. So moving towards the next session, that is very debatable topic, cord-blood blanking, from controversies to consensus. And for that, we have Dr. Bhaskar Pal sir as a speaker. And to chair the session, I would like to invite Dr. Charmila. She is ICOG Governing Council member, and she's has been chairperson, Clinical Research Committee, National Coordinator, UNICEF FOGSI PCA and MEDA FOGSI PG program. And she had been past secretary Trichy OBGYN Society, President Menstrual Hygiene Management Consortium. Welcome, Dr. Charmila.
Thank you, Amita. Thank you.
And I would like to welcome Dr. Lakshmi. She is a Secretary, Trichy OBGYN Society, Consultant, Malathi Hospital, Rana Hospital, Tiruchirappalli. And she has won C. Subramanian Award for the best outgoing student. Her field of interest is high-risk obstetrics. Welcome, Dr. Lakshmi. And I request Dr. Lakshmi to please kindly introduce the speaker for this talk. And
happy evening and weekend to one and all. It's indeed a great pleasure and pride to be the part of the scientific program, Sangam 14, organized by ISOPARB in association with Allahabad, Trichy and Bareilly OG Society. I thank Dr. Ranjana Khanna, founder, president of ISOPARB, Secretary Dr. Amita Tripathi, for making me a part of this program. We move on to the topic, cord blood banking, controversies to consensus. We know, like when we sit in our OPD, we have people coming and talking to us about this cord blood banking, and they'll ask you, like, will it cure this disease? Will it cure that disease? And most of it, we are not very sure. Probably we will just end up saying that, okay, some researches are going on in this, and we just have to wait and see. Now we have a very dynamic person, Dr. Jagsonpal Pharmaceuticals Vice President, here to talk on this. Dr. Jagsonpal, he is a senior consultant gynecologist, Apollo Hospital, Calcutta. He is the chair of AICC RCOG. He is vice president of AGE. He is the president, Bengal Obstetric and Gynec Society. He is the FOGSI representative, SACOG 2123. Most important thing, he is the chairperson of the organizing committee, AICOG 23, to be held at Calcutta.
That should be enough, madam. That should be enough.
So we move on to the talk. Over to Dr. Jagsonpal. We welcome you, sir.
Thank you. At the outset, let me thank Dr. Ranjana Khanna. I have not been accepting any speaking responsibilities for the next few weeks because too many things are happening together, including the IAG annual conference, AICOG, and our Bengal Society annual conference. But I cannot say to Dr. Ranjana, we've been co-VPs and we've had an excellent year together. And secondly, because of the topic, I do not think this topic is controversial at all. And I will go through the reasons why people still do umbilical cord blood banking. But Dr. Ranjana chose this topic, umbilical cord blood banking, controversies to consensus. And thank you very much for inviting me. And let's hope that not longer that we'll have to meet this way. Although I think virtual medium will continue for education, but we should be able to meet one another physically very soon. Now, the background is that the first umbilical cord blood transplant happened in 1988. By 2015, many transplants had been performed, over 35,000. And it was performed to correct inborn errors of metabolism, hematopoietic malignancies, and genetic disorders of the blood and the immune system. Now, why umbilical cord blood? Because the cord blood contains hematopoietic stem cells. Now, these proliferative cells are about 1 log fewer in number than can be obtained from the bone marrow or peripheral blood stem cell donation. But the reason they have an advantage is they have greater proliferative and colony forming capacity and are more responsive to some growth factors. Also, they are more naive than proliferative cells from the bone marrow, and they seem to produce fewer complications associated with some aspects of HSC transplantation, which means that the umbilical cord blood is a good source of stem cells. And umbilical cord blood transplant, the stem cell transplant using umbilical cord blood, is a very useful thing. In future, the cord blood might be a useful source of stem cells other than hematopoietic precursors. Reports suggest that not only are mesenchymal and neural precursor cells present, but that some cord blood cells present in extremely low frequency may have the capacity to develop into many different lineages, including cartilage, fat cells, hepatic, and cardiac cells. but the therapeutic role for such cells remains speculative. So what are the advantages of cord blood transplant? A faster availability, an extension of the donor pool. Cord blood transplantation will tolerate a mismatch of tissue types between donor and recipient greater than is acceptable with bone marrow or peripheral blood. And that is because, as I said, that they are more immunologically naive. So there is lower incidence and severity of graft versus host disease, a lower incidence of viral transmission, and lack of donor attrition. Deliveries will keep on happening and will take blood from the umbilical cord and keep giving it, unlike adult donors who might change their mind. What are the disadvantages of cord blood transplant? Low numbers of hematopoietic progenitor cells and stem cells in each cord blood donation, which may cause delayed engraftment. And that is what I was saying, that the amount of cells that you get is 1 log lower than what you'll get in the bone marrow. And the lack of availability of subsequent donation of stem cells and or lymphocytes from the graft donor in graft failure or disease relapse, because you do not have unending supply from the same source. Now, what are the sources of cord blood for storage? So I think what we need to first understand that the cord blood is a useful source of stem cells, and stem cell transplantation using cord blood is a very useful method. The question that comes is different. Now, where should this cord blood be stored? Should it be a directed donation or non-directed donation? A non-directed donation is where people give the cord blood to a bank and they have no ownership of the cord blood. And this cord blood can be used for transplantation for whoever needs it, just with a HLA matching, just like it happens with blood transfusion. And what is directed donation? Directed donation, when you donate the blood, you donate the cord blood for your own use. And that is something which has been going on in our country, especially in the private sector, quite a lot. Now, directed donation is of two types: directed donation in at-risk families and directed donation in low-risk families. Directed donation in at-risk families means when there is a sibling who suffers from a genetic disease, and there is an option of a severe sibling by IVF or PGD, or you can have another sibling and use that baby's cord blood for stem cell transplant. It can be used for siblings of babies who are suffering from hemoglobinopathy or from leukemia. But what are we going to talk about is what Dr. Ranjana Khanna meant, I'm sure, is whether there's any role of directed donation in low-risk families, which means that the cord blood companies go and approach every mother and go and say, please donate, this is going to be very useful for your baby. And that is where I'm going to look at in the next few slides. The cord blood banks are of two types. One is public cord blood bank and one is a private cord blood bank. Western countries, Canada, United States, United Kingdom have public cord blood banks where people give their blood, cord blood, they donate it, and the storage is free. And when it is needed, it can be used by anyone depending on need for a small fee. In India, there is a bank which actually gives out cord bloods for a price, but what we have more are the private cord blood companies. These are the for-profit companies, and it stores umbilical cord blood for personal use. They charge a cost of collection and a storage. You can pay a cost for collection and pay annual storage fee for up to 18 years, or you can do that all together at one go. And beyond 18 years, there would be a separate charge. And the charge is pretty steep. However, there is no guarantee that the blood will be useful for the individual and family member. And what we'll try to quantify is what is going to be the chance that a baby is going to need that blood for himself or herself or one family member. This is what we called as an autologous transplant, that when you collect the stem cell for your own use, the individual's chances of using the personal cord blood for hematopoietic disorders before the age of 20 years is estimated between 1 in 3,000 to 1 in 20,000, according to the RCOG in the statement published in 2006. The more recent statement from ACOG estimates the lifetime probability of an individual requiring an indication for autologous umbilical cord blood transplant ranges from 1 in 400 to 1 in 2,500. The SOGC statement also published in 2015 said that the chance that a person will contract a disease treatable by their stored cord blood by age 21, the reason we say 21 is we do not know after 21, every year there is a fall in the amount of stem cells that are there. And after 21, the number of stem cells that would be there are still doubts whether that would be enough to have a transplant, has been estimated approximately to 0.005% to 0.04%, very, very small. The Indian Academy of Pediatrics published their guideline in 2018, where they said that the likelihood that they will ever be used is remote, and the range estimates vary from 1 in 1,000 to 1 in 200,000, extremely small. There is another implication also. If you do a cord blood collection, you'll have to go for an early cord clamping. And we know that delayed cord clamping in term infants has been consistently shown to enhance placental transfusion at birth and increase the hemoglobin, hematocrit, ferritin levels, and iron stores up to the 6th month of age. And WHO recommends a 1 to 3 minute delayed cord clamping in term infants, particularly in populations where iron deficiency anemia is endemic, and provided there is provision for screening and treatment of neonatal jaundice, because there is a small increase in the risk of neonatal physiological jaundice when you do a delayed cord clamping. Now it comes to why is cord blood banking so popular? It is because this thrives on emotional blackmail. Just like the chairperson introduced that when we are not sure, and when we are not sure, easy for us to err on the safer side. If I do not know whether it is useful or not useful, and the patient comes and says that should I keep the cord blood? The easier default option of defensive practice would be yes, go ahead. Because if you say no, and later on the patient comes and tells you, well, I would have needed it tomorrow, and you told me not to do that, that is a risk. And many doctors do not go behind the science of the cord blood banking and are swayed by the persuasive marketing of the companies who promote cord blood banking. And this cord blood banking, apart from their strong marketing measures, they go ahead and ask your patients how they emotionally blackmail the patients. And they say, these are the different phrases that they use, and not in India, world over. Stem cells can only be collected at the time of birth. Rubbish, it can be collected from bone marrow as well. Unimaginable possibilities, but none of them are proven to be true. Once in a lifetime opportunity, that is like freezing a spare immune system, more like a sci-fi movie, but not science. Saving the key components to future medical treatment, only not proven that to be useful, and saving something that may conceivably save his or her life someday, of a chance of 1 in 10,000 to 1 in 200,000. So if my patients come and ask me, doctor, should I do an umbilical cord blood banking? I tell them that please go and put that money in the mutual fund in your child's name. And if ever your child needs an umbilical cord blood transplant, you will need only a fraction of that money we should have grown to get it from a public cord blood bank. Italy is the only one country which has banned private cord blood banking, but UK, US, and Canada have got strong statements where they discourage private cord blood banking and encourage public cord blood banking. I will end with what the current guidelines state, because they are pretty good, pretty much like the summary. SCOG in 2015 said that umbilical blood collected from a neonate cannot be used to treat a genetic disease or malignancy in the same individual in the form of an autologous transplant, because the stored cord blood contains the same genetic variant of pre-malignant cells that led to the condition being treated. The routine collection and storage of umbilical cord blood with a private cord blood bank is not supported by available evidence. Private umbilical cord blood banking may be considered when there is knowledge of a family member with a medical condition, malignant or genetic, who could potentially benefit from cord blood transplantation. So this is the only time when we can advise a directed private cord blood banking, when there's a sibling with a hemoglobinopathy or leukemia or an inborn error of metabolism. Public umbilical cord blood banking is the recommended method of obtaining umbilical cord blood for use in transplantation, immune therapies, etc. And this is possibly my last slide. And this is a very strong statement by the Indian Academy of Pediatrics in 2018, And it said that public cord blood banking should be promoted over private banking. Advertisements for private banking are often misleading, and legislative measures are required to regularize the marketing strategies of cord blood banking. In the United States, if a doctor advises a patient cord blood banking, they have to declare what are their commercial interests with the company and what kind of benefits they get from that company. And ICMR also has come out with an FAQs, which are more or less in the same line as IAP. The private cord blood banking is highly recommended when an existing family member, sibling, or biological parent is suffering from diseases approved to be cured by allogenic stem cell transplantation. Otherwise, private cord blood banking is not a biological insurance and should be discouraged. At present, autologous cord stem cells cannot be used for treating diseases of genetic origin, metabolic disorders, and hematological cancers. Thank you very much. And the last slide is also from the IAP statement. I think it was short, but I think I've been able to convince you there's absolutely no role of umbilical cord blood banking in a low-risk pregnancy where there is no family member who's suffering from a hemoglobinopathy or inborn error of metabolism or a leukemia. Thank you very much. I think this is what Dr. Ranjana wanted, and she's very happy. I can see that from.
Thank you so much, sir. Actually, there can be only one Dr. Bhaskar Pal. There can be only one person. You create a controversy, or you take a controversy and give some clarity and come to a consensus also. Beautifully done. Very clear. I think the message should have gone across. Do not encourage private cord blood banking, which all of us did 10 years back, seeing the heroines and heroes recommending that they do for their own children, thinking that our children also will be benefited. We know that it's useless now. So public cord banking should be encouraged actually, because it provides a pool for the public to use it, and we can also use it as a lesser cost than what we would have done with our children's cord blood being banked. Thank you so much for a wonderful talk, sir. It was a pleasure listening to you. Thank you, Ranjana ma'am and Dr. Amita.
Excellent presentation, Dr. Bhaskar Pal. Excellent presentation. Very good presentation. You have
in AICOG, if I remember rightly, in AICOG 2015 at Chennai, Golden Beach, Aishwarya Rai had come to promote.
Yes, absolutely. Absolutely. That is one of the marketing strategies, is to get a celebrity to endorse it. If you remember, there's this movie, I'm forgetting the name of the movie, which had Priyanka Chopra, where is this sexual harassment at work, and they are in an ad agency, and the boss comes and says that this car has nothing, it's one of the worst cars, how can we promote it? And his junior said, just get a celebrity, that's the only way this car would sell.
Yeah.
Aishwarya Rai will be angry with you. She lost advertisement.
And our patients were supposed to pay 70,000, 80,000, 1 lakh rupees and so on.
Madam, we paid for my sister, ma'am. It's lying useless somewhere. 80,000 we shelled out.
In my daughter's case, I consulted my niece in US. She said, it's outdated, totally outdated. We just have these public banks. So don't get it done. So I didn't get it done for her.
But ma'am, in India, we are not having the public banking.
There is a public bank.
Hyderabad.
There are a couple of public banks. I know one in Allahabad. Dr. Amita is saying there's in Hyderabad, where you can send your cord blood sample for free. They'll store it for free, and you have no ownership on it. They will sell it just like a blood bank, but obviously the cost would be much cheaper.
But they are the community banking, then your own sample is not required, it cannot be used, then you can use other sample.
Absolutely.
Yeah. If it matches yours, you can use.
Exactly.
For community banking, that is not for public, but still you may use another sample.
You have a higher chance of getting a match in a public cord bank compared to the blood you have stored. You have got a higher chance in a public cord bank because the HLA matching is much better there.
But then it will become their responsibility. They may
but anyway, even when you use the cord blood which you have stored, you have to pay to the company again. So the expenditure is already there. You have paid for the storage and you have to pay for the collection also. When you want to use it in any of your relatives, you have to pay again a high amount. So instead of that, when you give it to a... Yes, ma'am.
But LifeCell, they say that up to 20 lakh, it is insured.
20 lakhs?
You have to read the fine print there.
Yeah.
It is not available unless
I
you
don't
pay
know
or
of anybody. I don't know, obviously, the figures match because I don't know anybody, patients, friends, patients, and relatives who has ever needed that cord blood.
Needed.
So one patient of mine who had a child with thalassemia used it from the newborn. They took it for the sibling and they used
That's
it.
fine.
It was
That is
effective.
okay. That is, I have said, that is the only indication of doing a directed banking. That would be the only indication, because that is why we do not know what are the storage conditions. We do not know somebody needs it after 8 years. How much of stem cells will be found in that? Because they are actually going on the fact, why 20 lakh actually? Lifecell can offer a 50 lakh insurance, because what will happen? It goes on the fact that 1 out of 2 lakhs will require, 2 lakh people will require it. So if you take 1 lakh from everybody, so you got 2 lakh and 1 lakh in the bank. And every time somebody asks for it, don't even store the blood, just give them 50 lakhs. You still made a killing.
That is also good economics. Thank you so much, sir.
Thank you, sir.
Thank you, Bhaskar. Thank you so much.
I think you are happy with what you wanted me to do. Thank you.
Yes.
Thank you, sir, for the very clear message. With this, we move towards the next session. And I would like to invite my dear friend and Secretary of Allahabad Obstetrics and Gynae Society, Dr. Ritu Sinha, to handle the next session. Dr. Ritu Sinha, over to you.
Good evening, everyone. And I once again welcome all the esteemed faculties and delegates to the Scientific Sangam session. At the outset, I want to thank such eminent faculties to have given us insight on Doppler waves and the need for cord blood banking. Now, let us proceed on to our next session on a very important aspect of fetal surveillance, that is variable decelerations. And the eminent speaker is our very own founder president of ISOPARB Prayagraj, I should say rather, pride of Allahabad Society, Dr. Ranjana Khanna Madam. May I now welcome the expert for the session, Dr. Abhilasha Chaturvedi Madam, a very senior and renowned gynecologist of our own city. Ma'am is the director of Abhilasha Hospital and IVF Center and Clinical Child Image. She is the immediate past president of Allahabad Society and is a very dynamic and cheerful person. She has the reputation of giving first IVF baby to our city and introduced the concept of ultrasound technology to Allahabad way back in 1985. We are proud to have you with us, ma'am, today, and we welcome you. Now, I also welcome the chairperson for the session, Dr. Preeti Vash, madam, the president of Bareilly Obstetrics and Gynecological Society. Ma'am is the owner of Swasti Hospital, Bareilly. She did her MS from GSVM Medical College, Kanpur, and is now practicing in Bareilly for the last 27 years. We welcome you, ma'am, and request you to please introduce our speaker, Dr. Ranjana Khanna, ma'am. Over to you, ma'am.
Hello. Hello, everyone. I am highly thankful for you for giving me the chance in this webinar. Dr. Ranjana Khanna, ma'am, is a senior consultant and director of Ranjana Hospital. She is National Vice President, FOGSI 2017. She is ICOG Governing Council member 2021. She is President AOCOG Allahabad 2013 to 2016. She is Honorary Secretary Allahabad Obs and Gynae Society 2011 and 12.
I think Preeti, it's fine. Everyone knows me, I think.
Hi, everyone knows you are so sweet, so charming.
Thank you so much. Thank you so much, Preeti.
You are so sweet.
You can give your opinions once the talk is over. Today, I'm going to take on a topic which I used to actually dread speaking on initially, but it's a wonderful topic. And since we are still talking about the umbilical cord, the Funis of Life, so I proceed with variable decelerations. Variable decelerations are defined as irregular, often jagged dips in the fetal heart rate that actually look more dramatic than the late decelerations. Variable decelerations happen when the umbilical cord is temporarily compressed. It happens during most labors. The baby's blood flow, however, is reduced if the variable decelerations occur repeatedly. The onset of deceleration to the nadir, that is the lowest point, should be less than 30 seconds. Decrease in the fetal heart rate baseline should be at least 15 beats per minute and should last for at least 15 seconds, but less than 2 minutes. Variable decelerations can be periodic, that is associated with contractions, or episodic, that is not associated with contractions. The etiology. Variable decelerations can be seen resulting from fetal movement if the fetus is premature. In term fetuses, variable decelerations result from vagus nerve-mediated parasympathetic effect on the heart. The fetus, we all know, is well adapted to life in the uterus. The fetal hemoglobin differs from adult hemoglobin. The fetus has a more sensitive Bohr effect, which allows high binding and unbinding of oxygen in response to oxygen tension in the fetal circulation. The fetus has high basal blood flow to its organs and vascular shunts that preferentially deliver oxygenated blood to the heart and brain. Because of these adaptations, the fetus has surplus oxygen, which allows it to maintain oxidative metabolism even during mild to moderate reductions in the supply of oxygen, such as during uterine contractions. During a contraction, firstly, what happens? Umbilical vein alone undergoes compression. So the venous return to the heart of the fetus decreases, as a result of which there is subsequent baroreceptor mediated acceleration of the fetal heart rate. This appears like a shoulder on the tracing. Complete cord occlusion leads to increase in the fetal arterial blood pressure, and the resultant baroreceptor triggered activation of the vagus leads to rapid fetal heart rate decelerations. When contraction resolves, the deceleration also resolves. Now, when the uterus contracts, we all know that the uteroplacental perfusion is impaired, which leads to hypoxemia. So if this hypoxemia is mild, the fetus switches to quiet sleep or decreased movements and breathing. But at a certain threshold of hypoxemia, the peripheral chemoreflex is triggered, which increases the sympathetic and parasympathetic activity rapidly. This promotes centralization of perfusion to the critical organs, hypertension, and peripheral vasoconstriction. Because parasympathetic overrides the sympathetic activity in the heart, rapid deceleration is hence triggered. Now, what is the epidemiology? Intermittent variable decelerations are defined as decelerations occurring with less than half of the contractions, and it's most common in labor, not associated with adverse perinatal outcomes, and no treatment is needed. Recurrent variable decelerations occur with more than 50% of the contractions. It's less common and more concerning. So now we'll talk a bit about the basics. So as we can see in the E, we are showing the uterine contractions. Now we'll talk about the various changes in the fetal heart rate in context with the uterine contractions. First of all, A shows you the acceleration. As I have said earlier, first, initially when cord occlusion occurs, it is the umbilical vein which gets compressed. And because the vein is getting compressed, so the venous return, the blood flow to the heart is reduced, as a result of which vagus nerve is stimulated, and it causes an acceleration of the fetal heart rate. So in this we will see that the fetal heart rate is getting accelerated, and these are actually okay, and it happens in most labors. Now, early decelerations. When we compare it with the uterine contraction, we see that before the uterine contraction actually begins, the fetal heart rate starts dipping down, but the recovery is very quick, even before the uterine contraction has passed off. So these are also not ominous at all. Now we come to the variable decelerations of which we are talking about. So first, the umbilical vein gets compressed. There is an acceleration of the fetal heart rate in the tracing, and then there is this dip when the whole cord gets occluded. And normally, actually the deceleration is coming on even before the contraction has begun. And we must remember that it may or may not be correlated with the contraction. So this is a dip, and then it stays on for some time, and then the recovery takes place after the contraction has passed off. But see, this second dip which is occurring without any correlation to the uterine contraction. Now we'll talk a bit about the late decelerations. What happens in late deceleration? Uterine contraction has begun, and then the fetal heart rate starts dipping down, and the recovery is very slow. So the uterine contraction has finished, and long time after that, the fetal heart rate comes back to normal. So these are the basics. Now, variable decelerations, we'll talk about more of these. So this is the acceleration. This is a clearer picture and shows us the decelerations, a down dip of the fetal heart rate. But of course, see, it's around 110. Then these are the mild and severe variable decelerations. So we can see this mild one, where we see that slight acceleration is there, and then the fetal heart rate is dipping. But see, it's not going beyond 110. In fact, it's between 110 to 120. And then the recovery is also pretty sharp. But then we have these severe variable decelerations, where we see the dip and see the dip. It is coming to around 40 to 50 beats per minute. And then it stays on for such a long time. The uterus contraction has passed off, but still it's not recovering. And after a long time, it comes back to normal. So these are the very ominous fetal heart rate decelerations. These severe variable decelerations are very bad, and they normally precede bradycardia before uterine rupture. So immediate delivery has to be taken care of. Now, in a nutshell, we can say that variable decelerations are because of cord compression, early decelerations because of head compression, which happens in most labors. Acceleration is, well, okay. And late deceleration is because of placental insufficiency. So what are the predisposing factors? Prematurity, small variable decelerations are there. At term, low amniotic fluid volume, including, which could be because of rupture of membranes and oligohydroamnios. Cord compression, we have already said, is the most important reason. Nuchal cord, monoamniotic twins at risk of umbilical cord entanglement. Uterine rupture. See what happens, that is what I was saying, that deep variable decelerations occur and they precede the bradycardia, and then finally, of course, fetal heart gone once the rupture occurs. So history of previous classical cesarean and previous uterine rupture. Cord prolapse. This is a very important feature of, it could lead to variable decelerations, as in polyhydroamnios, breach, advanced cervical dilatation, or free head at term. Now, when you find that the electronic fetal monitoring is showing variable decelerations, first of all, check the ultrasound. See the number of fetuses, and if they are more than one, identify the chorionicity and the amnionicity. Now, put your hand on the patient's abdomen and see whether the uterus is very tightly contracted. Is there any gap between is it relaxing in between the contractions? And if the variability is there, another very important thing you have to do is do a pervaginal examination to first of all see whether the cord is prolapsing, because that could be a very important reason of the variable decelerations. See for cervical dilatation and the station of the head, like how quickly you can conduct the delivery. Now, coming to electronic fetal monitoring, of which we are talking about, electronic fetal monitoring, including identification of variable decelerations, has ultimate goal of preventing adverse perinatal outcomes. The efficacy of continuous electronic fetal monitoring is debatable. It has been shown to increase the rate of LSCS, operative vaginal delivery, and decrease neonatal seizures. It, however, does not reduce the perinatal mortality or risk of cerebral palsy. Why? Because non-reassuring fetal heart rate patterns predict cerebral palsy in only 0.14% of the time, and they have a false positive rate of more than 99%. Besides, the inter and intra-observer variability of FHR tracings, interpretation is very high. What does this mean? This means that if the same graph is given to chart, we can say, is given to 10 people, only 2 of the persons who are interpreting it will interpret it in the same way. That is only 20% accuracy will be there. The other will all interpret it in a different way. In fact, it has been seen that if the same person is given the same chart after, say, a period of 7 to 10 days, that person might also interpret it differently. So the inter and intra-observer variability of FHR tracing interpretation is very high. Now, differential diagnosis of variable decelerations. Intrauterine umbilical cord compression, which could be because of maternal fetal positioning, oligohydroamnios, nuchal cord or other cord entanglements, true knot or short umbilical cord, uterine tachysystole, pushing during second stage of labor, increasing fetal acidemia, umbilical cord prolapse or uterine rupture. How do you manage? Target of management is, see, the cause of variable deceleration is cord compression. So the target of management is to relieve the potential cord compression. So if the patient is lying on her back, shift her to the left lateral position. Amnio infusion, it improves the decelerations. LSCS rates, 5-minute Apgar score, postpartum endometritis, maternal hospital stay, and mean umbilical artery pH. This is, of course, useful only in cases of oligohydroamnios. Specific management is done according to the etiology. So cord prolapse, as soon as we find that the cord is prolapsed, immediately try to, and in the vagina, try to deposit it above the presenting part in the cervix and immediately inflate the bladder so that the pressure of the presenting part on the cord is relieved, and shift the lower part of the patient in a higher position and immediately shift the patient for LSCS. In the second stage of labor, maternal pushing efforts may also lead to variable deceleration. So tell the patient, do not push with every contraction and allow for adequate fetal recovery between the pushes. In uterine tachysystole, see, if the patient is undergoing induction of labor and we find uterine tachysystole, immediately decrease the amount of oxytocin, which is being administered, or you can even stop the drip or give beta agonist to reduce the contractions. If PROM has occurred, delivery is mandatory if there is non-reassuring fetal status, chorioamnionitis, or placental abruption. If the fetal heart rate is persistently abnormal and the patient is in the second stage of labor, we can try operative vaginal delivery. But if the patient is in early stages of labor, immediately go in for LSCS. And in breech presentation, the answer is yes, LSCS has to be done. Prognosis: intermittent variable decelerations are benign. Recurrent variable decelerations are associated with poor outcome, including neonatal acidemia. The peripheral chemoreflex response to hypoxemia is a tailored response. So an increasing severity of hypoxemia leads to deeper decelerations. Hypoxemia and fetal acidosis have correlations with meconium aspiration, metabolic and hematological disturbances, cognitive dysfunctions, encephalopathy, cerebral palsy, and death. Now, there are certain pearls which will end the talk. Intrapartum FHR tracings are divided into 3 categories. Category 1, it's normal. No action is required. Baseline 110 to 160 beats per minute. Moderate variability is there. There are no late or variable decelerations, which are the ominous ones. Early decelerations or accelerations may or may not be present. This is a picture which shows the category 1, and see the moderate variability is there, and there are slight accelerations sometimes, but otherwise overall this is a beautifully graph. This is a beautiful graph and very reassuring. Then category 3 we'll talk about, in which it is abnormal, prompt delivery is indicated. There's absent variability and recurrent late or variable decelerations, bradycardia or sinusoidal pattern. This is category 3, and we see, just look at that. This is absent variability, and these are the late decelerations which are coming on. So these are very ominous, and immediately delivery has to be done. And category 2 is actually everything in between. Indeterminate evaluation, intervention, and surveillance is needed. To conclude, in a patient without complications, review the fetal heart rate tracings every 30 minutes in the first stage and 15 minutes in the second stage. For patient with complications, review the fetal heart rate tracings every 15 minutes in the first stage, every 5 minutes in the second stage. But despite the ambiguity surrounding fetal monitoring, obstetricians and nursing staff must work collaboratively, especially in cases of variable decelerations, so that both mother and baby receive the best care and therapeutic interventions are taken at the right time. Thank you so much.
Thank you, Dr. Ranjana ma'am, for this lucid and illustrious presentation. And may I now request Dr. Abhilasha Chaturvedi ma'am to give her expert views.
The discussion was fantastic. Ranjana is a great speaker, but I have few concerns. Few concerns are, you already said that continuous monitoring is already a controversial issue. So if you don't do continuous monitoring, how will you pick up them? Another thing, let me express my concern. Another thing, interpretation is also subjective. They are not very objective. So first these two things, then I'll come.
That is because that is where your clinical acumen also comes in, na? So you have to be very well aware of the etiology of also, and they have said na that every 30 minutes you go in for, if it's otherwise normal, so every 30 minutes go in for EFM.
So that means continuous monitoring. Is it practically?
That is the debate. That is the debate actually, that EFM
In fact,
I think it should only be done if there is, it's a high risk patient. Then it has to be done.
In high risk patients, you do a cesarean directly. Don't go for all this continuous monitoring. But this is very useful. Really practical importance is when at 2 a.m. a patient is admitted in your nursing home with lots of fetal movements. Then the nurse can do her CPG and she can send this with the image with Wi-Fi to you, and then you can make decision. Is it cool or it's alerting?
True.
So I think this is the only practical potential.
Yeah. And the main idea was to tell everyone what actually variable decelerations, which are the omnious ones which come on.
You are a wonderful speaker. There is no question about it. But the only thing is practicality of any investigation is very, very important.
True.
So I again congratulate you for organizing such a great conference. Thank you.
Thank you.
Thank you so much, Abhilasha ma'am, for your expert opinion. And thank you very much, Dr. Ranjana Khanna ma'am, also for a wonderful deliberation. And now we quickly move on to our next session. The speaker for this session is a young and accomplished teacher, Dr. Sinha Jamal. Sorry, please excuse me. Dr. Shehla Jamal. She will deliver her talk on cord clamping early or late. The expert for this session is Dr. Lalita Shukla ma'am, a very dynamic president of our own Allahabad society. She is the senior gynecologist at Arogya Niketan Prayagraj and ex-chairperson AMA Women's Wing. We welcome you, ma'am. We are also privileged to have Dr. Pragati Agarwal ma'am, Secretary Bareilly Obs and Gynae Society, as the chairperson for this session. She is the consultant at Pragati Hospital Bareilly. She did her MS at GSVM Medical College Kanpur with gold medal and invited as faculty in various national conferences and is practicing at Bareilly for the past 25 years. We are privileged to have you here, ma'am, and request you to kindly introduce our speaker, Dr. Shehla Jamal.
Thank you, Dr. Ritu, for such kind words. And I would like to give thanks to ISOPARB Prayagraj for including our society. This topic, cord clamping early versus late, it is very important. There are so many benefits of delayed cord clamping in term and preterm infants. And therefore, all organizations now recommend delay for at least 30 to 60 seconds. or even up to 3 minutes after birth. Dr. Bhaskar Pal also told about the benefits of delayed cord clamping. But in some circumstances where fetus is compromised or in abruptio placentae, etc., we don't delay cord clamping. Our speaker will tell everything in detail. And speaker is none other than Dr. Shaila Jamal. She is also the member of our Bareilly Society. It is my proud privilege to introduce her. She is Associate Professor, Rashri Medical College and Research Institute, Bareilly. She is the founder and president of Society of Menstrual Disorders and Hygiene Management, India Book of Records holder, Joint Secretary, GNOGS, Chief Editor, Journal of Reproductive and Menstrual Sciences, social activist and writer. She is North Zone in charge of YTP FOGSI, Coordinator Endocrinology Committee, member IAEC Breast Committee FOGSI, Core Committee member RNTEP. And at such a young age, she has been awarded so many awards. FOGSI Leaders of Tomorrow Award, FOGSI PAC Award, Award of Honor by WHO, Award of Excellence in Menstrual Hygiene Promotion by Gramalia and Ministry of Sanitation and Drinking Water, 39 publications and chapters, contributed 2 chapters to FOGSI Focus, organized many state-level conferences, gold medal in PG and UPCOG, India Book of Records holder. I welcome Dr. Shaila Jamal to give her talk.
Thank you so much.
Really, we are proud that she is in our society, in Bareilly Gyne Society.
Ma'am, I'm also equally proud to be associated with you. And with that, I will utilize this opportunity to pay extreme gratitudes to Ranjana ma'am for giving me this opportunity, Amita ma'am for it's my gratitude, and I'm Dr. Shaila Jamal. I'll be talking on a very cute topic rather, cord clamping, early versus delayed. Already we all know the consensus, it has to be delayed, but from where has it come? What are the benefits? And is there something else we can look up to other than delayed cord clamping? So what has the history told us? Umbilical cord has always been a very, very important part of childbirth. It was seen as a spiritual organ. Bible speaks about it. Mention of retained placenta, PPH, and umbilical cord severing is also present. Hippocrates postulated its role in fetal nutrition, and Aristotle was the first one to say that it is harmful to cut umbilical cord too soon after birth. In some cultures, cord was not cut until several hours after birth. If we go by the taboos that were associated with cord, people believed that if cord was cut too soon, they believed that roots of the placenta will just stick to the uterus and so badly that it can even kill the woman because it will not come out easily. So people believe that it was something, a bad omen kind of stuff. If we cut the cord too soon, there will be retained placenta. And in those times, majoritarily people were dying because of this. Regarding cord length, it matters to a lot of people because the baby breathes from cord, and it was believed that it is a breathing organ for the cord for the fetus in utero and even outside. Some people said we cut and tie the cord and then we make a dot of blood on the mother's and baby's forehead using the end of the cord so that the blessings of mother and baby are always associated with this dot of blood. In our own country, several case reports have been reported in literature that eating fallen umbilical cord cures infertility. And interestingly, they reported 57 cases. In all the 57 cases, it was believed that fertility enhanced, resumed after people ate around 1 centimeter of fallen stump of cord, which was embedded into the banana. And interestingly, they told that it tasted tasty, nice also. It was not that bad. Some people believe in Zambia that if one wants to put things around neck when we are pregnant, then even the cord will be long and it will go around the baby's neck, thus it will form nuchal cord. In Uttar Pradesh, it is believed that mothers should not carry handbags or tie anything very tight because then the baby will be born with the cord around neck. with such mysteries, such beliefs, timing of cord clamping had to vary among different believers. Until 7th century, ligating maternal end became justified to prevent spoiling. In 20th century, it was started that cord be clamped before placental delivery, and it became almost a norm. And before the mid 1950s, this timing, how and when the cord should be clamped, was defined, and it was believed that umbilical cord clamping within 1 minute of birth was early, and late clamping was defined as umbilical cord clamping more than 5 minutes after the birth. So when we say that cord connect is the heart connect, definitions had to come. So as I have highlighted previously also, cord was considered a spiritual organ. So everywhere it was a different practice to cut cord at different times. The professors of early cord clamping believed that it should be severed within 15 to 20 seconds. And the proponents of late cord clamping believed that it should be deferred till at least 30 to 60 seconds after birth. So scientific bodies had to intervene for creating a consensus, and now latest in 2020, ACOG came and suggested a delay in umbilical cord clamping in vigorous term and preterm infants for at least 30 to 60 seconds. NICE guideline says that cord is not to be clamped in the first 60 seconds of the birth, and it should be clamped before 5 minutes. So 60 seconds and 5 minutes. FIGO and WHO recommend cord clamping at around 1 to 3 minutes after the birth, and that was in 2015 when WHO revised recommendation about active management of third stage of labor. So now we have early within 30 seconds and delayed at least 1 to 3 minutes after the birth. And this is what the consensus of all over the world, across the globe, that is being followed. And it is important to note, especially for research purpose, when we generate outcome, whether early or delayed is scientifically followed or not. In our own country, Ministry of Health and Family Welfare 2018 SOPs for Lakshya protocols in labor room has recommended that it has to be delayed between 1 to 3 minutes. So this is what Ministry of Health and Family Welfare guidelines are saying. Until 2019, when Ministry of Health and Family Welfare issued an important notice, they said that the cord clamping can be waited between 5 to as long as 15 minutes. So till natural expulsion of placenta with numerous benefits, and it's a good article, good read, where they have tabulated each and every study that was conducted across the nation, and beautiful data has been collected. And I believe this is first of its kind data from India around cord clamping, timing and benefits. So what are the benefits that we reap when we delay this cord clamping? In term infants, we all know hemoglobin and ferritin levels are improving, and they have a favorable effect on developmental outcomes of the baby. In preterm infants, now this is the point where we presume that there will be a lot of volume overload. That is why early cord clamping was recommended. But it is not true. In fact, this is bringing a lot of benefits in the form of increased RBC mass, increased RBC volume, decreased need for blood transfusion, and lower incidence of necrotizing enterocolitis and intraventricular hemorrhage. And these two benefits have been studied until recently, and they have proven that one should be going for delayed cord clamping in premature infants too. Now, physiologic studies in term infants have shown the transfer from the placenta of approximately 20 ml gain at 3 minutes after the birth. See, at 1 minute, 80 ml is transfused. At 3 minutes, 20 milliliter more is being transfused. So this should not be just like 20 ml hi to hai. It is bringing huge benefits in terms of economic ratios also. Because if this 20 ml blood has to be transfused, an additional cost of 9 to 10,000 in terms of everything, right from top to down, will go down, and we will save this much amount of money to the mother, to the economy, to the government, and to ourselves also. So DOPPLER studies have also suggested that delayed cord clamping facilitates iron transfer, and this is especially aided by few breaths which a newborn takes. 40 to 50 milligram per kg of body weight of extra iron has been shown to reduce and prevent iron deficiency anemia during the first year of life. In addition to it, huge benefit, immunoglobulins and stem cells. Bhaskar Pal sir has also told about these things. And these are essential for tissue and organ repair, which is imperative in preterm infant. They're suffering from hypoxic damage in almost every organ. So if we give them this extra benefit of blood, which they are gaining from delayed cord clamping, this is beneficial after cellular injury, inflammation, and organ dysfunction. Now, regarding long-term effect, there was one study, and it was assessed from 4 months to 4 years of age. These children in early cord clamping group had modestly lower scores in social and fine motor domains compared with delayed umbilical cord clamping group. So again, fine motor and social skills, very important. They are also better in delayed cord clamping group. So do we have any harmful effects? Why we should talk when we have a consensus? So let us have a look, because maternal concerns are important. But it is now proven beyond any doubt that does not increase the incidence of PPH, does not reduce postpartum hemoglobin levels, and does not increase incidence of postpartum blood transfusion. In a review of 5 huge trials adequately that included more than 2,200 women, they have shown that none of the concern that we were thinking is true. But early cord clamping is suggested when a patient is having hemorrhage and requiring resuscitation, patient is already having hemodynamic instability, or there is abnormal placentation, as in case of abruption or previous. Regarding neonates, so let us have a look. In term neonates, polycythemia is non-significantly elevated. Overload, no. Jaundice is a bit higher. But when we see that how many of these infants require phototherapy, it is not significant. So although the rates of jaundice is higher in term infants which are having receiving delayed cord clamping, the requirement of phototherapy is not significant. So this requirement of phototherapy and a slight higher incidence of jaundice should not stop us from having or offering a delayed cord clamping. In preterm infants, all our fears are laid to rest. There is nothing which we should fear of. In fact, delayed cord clamping among infants born between 32 weeks of gestation was associated with improved motor function at 18 to 22 months corrected age. Early cord clamping, when we look from the fetal or neonatal perspective, is when a fetus is requiring immediate resuscitation, but we have one solution for this also. When there is incidence of placenta previa or abruptio, cord avulsion, or there is FGR baby being born, and this baby showed abnormal Doppler indices before delivery. So now coming to technique, what is the best practice that we can have? When we are delivering babies vaginally, we can keep the neonates to chest or abdomen, maintaining skin to skin contact, because it was believed that if we keep baby a bit lower down, due to effect of gravity, more blood will come. It is not so. So you can keep the baby for skin to skin contact. In fact, start drying the baby with linen, and early newborn care has to be initiated. So all the worry is gone. When we are doing cesarean, put the baby on maternal chest or legs close to placenta, and don't just try to push it out or pull it out of the baby, hurry up, because youngsters, they believe that doing a fast surgery is mark of excellence. So they try to hurry up, fatafat, do the cord clamp and hand over the baby to pediatrician that our job is done. I have done cesarean in 12 minutes, 30 minutes, 40 minutes. So there should not be hurry, because you are actually depriving the benefits that the baby can get because of this 1 or 2 minute. I don't know what will be done on those 1 or 2 minutes. So that should be abandoned. Now, if the baby is meconium stain, if the baby is rigorous and breathing spontaneously, go for delayed cord clamping. Until and unless the baby is depressed, requires resuscitation, no early cord clamping. Active management of third stage of labor should not be deferred for delayed cord clamping. Do uterotonics and everything, whatever is recommended. But yes, a bit concerned about cord pH levels in acidotic babies. Not huge data is available, and maybe this is an area of future research that we all can take up in our studies. So regarding the thing I was talking, do we have any substitute for early cord clamping? We want to give blood to resuscitate the baby also. So umbilical cord milking, which we saw our teachers doing, can be a substitute for DCC. Studies have come, but in 7 studies in 500 preterm infants, high levels of hemoglobin and good maintenance of blood pressure was seen. In term infants, however, delayed cord clamping is giving the same benefits as milking of the cord. So term you can avoid, but preterm you can do. In 2019, when a study was halted, which recruited almost 474 preterm infants, because in the preterm infants between 23 to 27 weeks, they developed huge incidence of intraventricular hemorrhage in cord milking. So cord milking should be avoided in extremely premature age group, but it is good for preterm. Equal benefits of cord milking and delayed cord clamping in term infants. So it should be avoided. Now coming to a point, multifetal gestation. So we have insufficient evidence regarding this, but theoretical benefits are still present. Caution has to be practiced in monochorionic twins. Cord blood banking, much have been said about this, but delayed cord umbilical cord clamping significantly decrease the volume and total nucleated cell counts of cord blood donations when delayed cord clamping is done. So we have to counsel the couple accordingly. What benefits you want to reap? The immediate one, that the baby will be good, or the delayed one that you are looking for. So counseling plays a majority part in when we are doing delayed cord clamping, especially banking. So to conclude, delayed cord clamping in term infants by at least 30 to 60 seconds. There is in jaundice. We have to be just prepared for this thing. In maternal benefits and proposed harmful effects, there is no increase in PPH, blood transfusion, or drop in hemoglobin levels. So we are safe. In preterm infants, not only hemoglobin, ferritin, and blood pressure are maintained, it reduces intraventricular hemorrhage and necrotizing enterocolitis, which I think deserves a clap if we are doing DCC in this age group. And early cord clamping has to be instituted where there is maternal or neonatal resuscitation is required. So with this, I end my talk and would like to extend my gratitude to Ranjana ma'am, to Dr. Amita Tripathi ma'am, to Preeti Vaish ma'am, and to Pragati Agarwal ma'am for giving me this opportunity and having me here. Thank you.
Thank you, Dr. Shehla, for this excellent and informative deliberation. You are truly an accomplished teacher, as I said earlier. And now I request Dr. Lalita Shukla, madam.
Ritu,
please.
Ritu, can I ask a question?
Yeah, sure, madam. Please.
Of course.
Yes,
ma'am. What about the RH incompatibility? But that should always be mentioned, because in our times we have been always teaching people that there are only few indications for an early cord clamping. One was fetal distress. The first one was RH incompatibility. The second one was the fetal distress, and the third one was the twin pregnancy. So one should always mention there is a categorically indication of early clamping in cases of RH incompatibility.
Yes.
Thank you.
True, ma'am. True, ma'am. Absolutely true.
Now I invite Dr. Lalita Shukla ma'am to give her expert views.
Thank you, Dr. Shehla. You have made it absolutely clear that a minute spent during labor goes a long way in preserving the health and the hemoglobin status of the baby. Not just then, but for the next 6 months, or maybe it may give an extended life benefit to the baby. And especially in a country like India, where most of us have any hemoglobin deficiency and all sorts of problems, I think it will go a long way to help us. So whenever we are in the labor room, and half the time we are so worried, we are so concerned about other factors, I think all of us need to keep this fact in mind, that has to be done unless there's things like RS negative baby or some other contraindications. Although milking of the umbilical cord, I think it does have benefits in some, if not all. And keeping the baby down, in fact, or keeping the baby up doesn't make any difference. And the skin-to-skin contact does matter. In fact, in some societies, I believe they don't clamp the cord till the placenta is delivered. So maybe it has its own benefits as such, although we don't do that, but I think it does. So thank you so much. It was very enlightening, and all of us learned a lot from your lecture. It was good.
Thank you.
Thank you, Lalita Shukla ma'am, Dr. Pragati Agarwal ma'am, and Dr. Shaila for this wonderful session. And I think with this, we don't have much of questions. Do we have some questions? Let me check it.
Yeah, there seem to be two.
Yeah. What about the delayed cord clamping in HIV, HBsAg, and other maternal infections?
Okay, in maternal infections, if you are taking CRP, elevated leukocyte count as a marker, it is not recommended. You can go for delayed cord clamping. But in HIV, Rh negative and twins, especially monochorionic twins, early cord clamping is recommended.
One more question is there, but it is about the cord banking. Actually, can we use other cord blood? It is, who's going to answer this?
Yes.
Dr. Ranjana Khanna ma'am, please, would you like to?
Of course, you can, because public banks, when they are available, so you can use other cord bloods.
Yeah. Thank you, ma'am. Thank you very much. Now with this, we come to the end of the session. And now I request Dr. Parul Khanna to please propose the vote of thanks.
Dr. Ritu, before Dr. Parul takes the Jagsonpal people will say a few words, then Parul will propose vote of thanks.
Yeah, sure, please.
Introducing, for the first time in India, micronized dydrogesterone, DIVATRONE. For a safer and smoother journey to motherhood, Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for DIVATRONE.
Thank you so very much to the ISOPARB Prayagraj for associating with us for this Scientific Sangam 14. And we present to you DIVATRONE, our newly launched micronized dydrogesterone 10 mg tablets for a safer and smoother journey to motherhood. Apart from that, we have Maintane injections and Maintane tablets of L-isostanol, injections of hydroxyprogesterone caproate 250 and 500 mg. LycoRed Preg sachet containing L-arginine, lycopene and DHA to prevent pregnancy complications. And of course, do give us support for our newly launched brand of DIVATRONE. We would like to invite you for tomorrow's Saving Mothers is a 2-day conference which is going on. One was yesterday was the workshop, and tomorrow is going to be a full day of CME by Haryana Obs and Gynae Society, that is Harop Gyne. Tomorrow from 9:30 a.m. anybody interested can register now on the Zoom ID displayed. So now we'll be going over to Dr. Parul.
Yeah.
Yes, ma'am. Thank
Good
you.
evening, everyone. It's time for official vote of thanks. I begin with thanking the Almighty for keeping us hale and hearty so that we can attend such webinars. I thank our organizing committee of the webinar, ISOPARB Prayagraj, in association with Trichy, Bareilly and Allahabad Obs and Gynae Society. I also thank our organizing chairperson, Dr. Ranjana Khanna ma'am, who is founder president, ISOPARB Prayagraj, for the inception and execution of such a great webinar series on the umbilical cord, the Funis of Life. I extend my thanks to our chief guest, Dr. Meera Agnihotri ma'am, teacher of teachers, for her blessings and sparing her valuable time. Now I thank our speakers, Dr. Narendra Malhotra sir, who taught us in detail about the analysis of color Doppler waves and when to intervene. Dr. Bhaskar Pal, who spoke on cord blood banking and gave the clear message that public cord blood banking should be promoted over private cord blood banking. Dr. Ranjana Khanna ma'am, who taught us in detail about the interpretation of variable decelerations and when one should intervene in such scenarios. Dr. Shehla Jamal,
who cleared the controversy of early versus delayed cord clamping, gave us the advantages of delayed cord clamping and case scenarios where one should revert to early cord clamping. I now thank our chairpersons, Dr. Malathi Prasad, Dr. Madhvi Mittal ma'am, Dr. Charmila Ayyavu, Dr. Lakshmi Prabha ma'am, Dr. Abhilasha Chaturvedi ma'am, Dr. Preeti Vash ma'am, Dr. Lalita Shukla ma'am, and Dr. Preeti Agarwal ma'am, who gave their valuable expert comments and crisply summarized the lectures. I extend my thanks to my co-conveners, Dr. Amita Tripathi ma'am and Dr. Ritu Sinha ma'am, who conducted the webinar flawlessly. Special thanks to ICOG for granting us 3 ICOG credit points. And last but not the least, our academic partner, Jagsonpal Pharmaceuticals, for helping us organize the webinar. Thank you all.